This is my song, O God of all the nations, a song of peace for lands afar and mine. This is my home, the country where my heart is. Here are my hopes, my dreams, my holy shrine. But other hearts in other lands are beating, with hopes and dreams as true and high as mine. My country's skies are bluer than the ocean, and sunlight beams on clover leaf and pine. But other lands have sunlight too, and clover, and skies are everywhere as blue as mine. So hear my song, O God of all the nations, a song of peace for their land and for mine. This is my prayer, O Lord of all the kingdoms. Thy kingdom come, on earth thy will be done. Let Christ be lifted up till all shall serve him, and hearts united learn to live as one. So hear my prayer, O God of all the nations. Myself I give thee, let thy will be done.
Yehowa nzambi udiukeba bantu bwakumwenzela mudimu wende mudimu munene tuyayiboso tumwenzele mudimu wende nemoyo umwe mudimu munene tuyayiboso tumwenzele mudimu wende nemoyo umwe nentume kwamba lumurize nentume bengatiliso mudimu wa nzambi kawengane bawenji nyabami kwabo mudimu munene munene tuya iboso tumwenzele mudimu munyabani kwabo mudimu munene tuya iboso tumwenzele mudimu munyabani kwabo Bantu banzambi twenza iboso mudimu wa yehowa nemoyo umwe tulekele mpata bijanu mukoso tumwendele mudimu nemoyo umwe tulekele mpata bijanu mukoso tumwenzele mudimu nemoyo umwe nentume sani enyiwanyi naye wakwamba lumurife nentume sani enyiwanyi naye wakwamba lumurife untume kameme kameme untume nenye wakwamba lumurife kameme 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 untume nenye wakwamba lumurife untume kameme kameme untume nenye wakwamba lumurife.
Welcome to the second session of the Congo Mission Network's 2020 conference. Bienvenue à la deuxième session de la conférence 2020 de Congo Mission Network. Today and next week, we will be presenting information about healthcare in the time of COVID-19 and its effects on healthcare systems both in the United States and in Congo. Aujourd'hui et la semaine prochaine, nous présenterons des informations sur les soins de santé à l'époque de COVID-19 et ses effets sur le système de soins de santé aux États-Unis et au Congo. Our session for today is as follows: a brief history of Presbyterian healthcare work in the Congo. 2. Current health issues and practices with COVID-19 in Congo as compared to the United States. And 3. Stories from people who have had personal experience with COVID-19.
Notre programme pour aujourd'hui est le suivant. 1. Une brève histoire des œuvres de la santé presbytérienne au Congo. 2. Questions et pratiques actuelles en matière de santé avec COVID-19 au Congo par rapport aux États-Unis. Histoire de personnes qui ont une expérience personnelle avec COVID-19. Pendant que vous écoutez ces présentations, veuillez taper vos questions pour le présentateur dans la case chat de Zoom. N'attendez pas la fin du programme.
Here's how to enter a question in chat. Click on the chat icon at the bottom of your screen on a computer or on the 3 dots More screen, and then choose Chat on most phones. Select To Charlotte White at the bottom of the chat window and then type from your name to the name of the presenter you wish to respond, followed by your question, and then hit Enter to send the message to Question Charlotte.
Voici comment entrer une question dans le chat. Cliquez sur l'icône Chat au bas de votre écran d'ordinateur ou cliquez sur le 3 points plus de l'écran et choisissez ensuite Chat sur la plupart des téléphones. Sélectionnez To Charlotte White en bas de la fenêtre de chat. Puis tapez de votre nom au nom du présentateur auquel vous souhaitez répondre, suivi de votre question. Appuyez sur Entrée pour envoyer le message à Question Charlotte.
Next week, on Saturday, October the 10th, at this same time, we will present the second session on healthcare in the time of COVID, together with a longer period of questions and answers. If during the coming week you think of questions or comments that you want to make, please send them to questionsforcmn@gmail.com at any time.
La semaine prochaine, le samedi 10 octobre, à cette même date, nous présenterons la deuxième session sur les soins de santé à l'époque du Covid, ainsi qu'une période plus longue de questions et réponses. Si au cours de la semaine prochaine, vous pensez à des questions ou des commentaires que vous souhaitez faire, veuillez les envoyer à tout moment à questions@gmail.com. Permettez-moi maintenant de vous présenter nos 3 premiers orateurs qui présenteront l'histoire du travail des presbytériens dans le domaine des soins de santé au Congo. Le Dr Richard Brown, avec sa femme Judith, ont fondé le Overseas Medical Fund il y a plus de 30 ans pour soutenir les collègues soignants et assurer un travail médical continu au Kenya, au Congo et en Haïti. Le Dr Richard Brown a été directeur médical de l'hôpital de Boulapé et a fait partie du personnel de l'IMCK. Une grande partie de sa carrière a été consacrée à la santé publique et à la prévention de maladies. Avec Judith, il a effectué un travail de pionnier dans la rédaction de la propagation du VIH-Sida dans le monde.
I want to give a brief history of the Presbyterian medical work in the Belgian Congo from the years 1906 to 1960. If you have a look at the map of Africa, you can see that the equator runs right through the upper third of the Belgian Congo. Another map shows the Congo enlarged, and you see it's divided into 4 language areas: Swahili on the east, Lingala in the upper west, Congo to the west, and Chiluba speaking area right in the center. That's where most of the Presbyterians did their medical work, and it's now called the Kasais, the territories where Chiluba is spoken. I like to look at the Presbyterian medical work in 4 different periods, about 10 to 15 years each. The first 8 years, we would say the first period, then the 5 hospitals period, then the Great Depression and World War II period, and the World War II towards independence period. So the first 8 years, from 1906 to 1914, started by Dr. Llewellyn Coppage, the first Presbyterian medical missionary in Belgian Congo. Here's a picture of Dr. Coppage. He was from North Carolina. He went to the medical school at the University of North Carolina, and 2 years after graduation came to the Congo. He did outstanding work there and was recognized by the King of Belgium as a Knight of the Order. The first 8 years, though, Dr. Coppage, arriving in 1906, had problems with malaria, and the number 1 problem of the Congo, even to this day, sleeping sickness and dysentery. He had no antibiotics, no vaccines, no sterilizers, no clinic or hospital facilities, and therefore he had to do home visits. He did what he could for the Congolese, which wasn't too much in those days. He often had to care for the missionaries and the Belgian officials since he was the only doctor in the area. The first missionary nurse, Elder Fair, arrived in 1913. She was followed by more women medical people, nurses and medical technicians. These women were either single or they were married to other Presbyterian missionaries. If we look at this picture taken early on, you'll see that Dr. Coppage is right in the center, and he grew a mustache. In front of Dr. Coppage is William Shepherd, the first missionary to the Congo, and over towards the right, second from the end, seated is Dr. William Morrison, the great linguist who put the Chiluba language into writing, wrote the first Chiluba dictionary, the first Chiluba grammar, and translated the New Testament into Chiluba. But it's interesting, if you look at this picture, how many of these were African American missionaries. In fact, there were a larger percentage of African American missionaries in the earlier days than they are even to this day. Many of these early missionaries were the children and grandchildren of slaves. Many of the white missionaries were the children and grandchildren of slave owners. But we look at the next part of the mission work, we would say the 5 hospital period. Now, the year 1908 is very important to the Congo because up to that time, the Congo was regarded as the Congo Free State, which really was almost the personal property of the King of Belgium, Leopold II. This was a time when rubber was starting to be used in automobile tires in Europe and in the United States. And so the King of Belgium invested heavily in getting rubber from the raw rubber trees in the forests of the Congo. But he used techniques which were brutal and terrible, and his agents were so terrible there that there was an international outcry against his agents in the Congo, and the government of Belgium took over the running of the Belgian Congo in 1908, a very important date in that story. The Belgians' new agents recognized the value of mission work. The medical personnel and the PCS missionaries support arrived. 5 hospitals were constructed and staffed, and these hospitals were strategically located. Nuevo was the first hospital built, and 4 other hospitals followed. Have a look at this map. You can see that Nuevo in the upper left-hand corner was at the end of the Lua River. Now one could travel from Nuevo down to Leopoldville or Kinshasa these days by about 1,000 miles of flat water, and it was done by riverboat. But the river got too shallow and they had some rapids at Nuevo, so that was the end of the line. The Belgian authorities had an official office on the southern bank of the Lua River, and so the Presbyterian missionaries were accorded the northern bank of the Lua River at Nuevo, and here was built the first hospital. Other Presbyterian hospitals, one was at Mutoto in the center of the country. Further east was a hospital at Bibanga. Then back there was Libondai was a hospital, and up to the north of the Nuevo was a hospital at Bulape, which was in the Bakuba Kingdom. Now, if you are going to Nuevo, you would usually take the riverboat. This is a picture of the Lapsley, which for many years transported missionaries and medicines from the capital of Leopoldville to Nuevo. In the 5 hospital periods, we look at a bit at the hospital at Nuevo. They were built of brick. There were hospitals and schools and churches and so on there. The next hospital was Mutoto, which actually became the largest hospital in the Kasai for some time. The hospital at Bulape was next, hospital at Libondai, and the hospital at Bibanga. During this 5 hospital period, we have pictures of 5 of the early doctors, Dr. Chapman, Smith, and Sticksrud, and in the front row, Dr. Kellersberger and Dr. Kusar. Too bad we don't have pictures of the other medical people or even of the women medical personnel, but we have what we have. The 5 hospital periods were concerned with treating malaria, leprosy, dysentery, measles, sleeping sickness, scabies, tuberculosis, and they had no antibiotics. Imagine practicing medicine without antibiotics. Surgery was for complications of childbirth, hernia, goiter, prostatism, cataracts, tumors, and cysts. Dental extractions were done by a minister. A few Wiles came for one term out to the Congo, and he saw the need for some dental care. He went back, and on his first furlough, he took treatment on how to extract teeth. He didn't do fillings, he didn't do any dentures or things like that, but he did extractions. And when you have a toothache, you want to get rid of it. And so Hugh Wiles was the dentist for the Kasai, and he was greatly appreciated. Then there was a training of nurses' aides. It was required by the government that you train hospital people, and every hospital went into training nurses' aides to carry on the day-to-day medical work. Next, we go to the Great Depression period. The Great Depression hurt missions worldwide. In the Congo, the medical services stalled. The Lapsley riverboat was sold in 1930. Budgets were cut, salaries were reduced, war reduced the ocean transport, supplies didn't arrive, personnel were cut and services slowed. Furloughed missionaries were kept home, and in 1942, only one doctor remained in the Kasai, and that doctor was Dr. William Rule, and we see in this picture he was holding something that looks like a liver, but I really don't think he was doing liver transplants in those days. Then we move on to World War II and to independence. There was a new vitality that emerged after the war in the Congo and in the Kasai. The Belgian government improved their clinics and hospitals. The mission hospitals were subsidized and given medicines by the Belgian authorities. Penicillin, streptomycin, and sulfa drugs became available. Surgery improved and expanded. Dentistry flourished. Public health projects started to control tropical diseases such as sleeping sickness and yaws. During this time, the offices the church moved from Nuevo to Kananga. Rail and roadways were greatly improved. the schools were started both by the government and the missions. Almost every station had a school. Dr. Mark Poole at Boulevarde brought an airplane there and had the first airstrips of the Kasais. Medical services he extended to distant medical clinics by air. Oh, yes, here's a picture of Dr. Poole with his friends in front of his new airplane at Boulevarde. Over at Banga, Dr. Kellisberger pioneered studies in sleeping sickness and leprosy. He later was appointed the president of the American Leprosy Mission when he left the Congo. Here's some of his sleeping sickness patients at Banga, and here's a picture of the eminent Dr. Eugene Kellisberger at Banga. At Lubondai, there was a birthplace of the Institut Chrétien de Versailles, INCK. The classes were started to train government-certified nurse practitioners, and they had to pass the government exams. The plans were made to move IMCK to the capital of the West Kasai, and here's a picture of some of the early graduates at Lubondai. So the Presbyterian mission work in those early days was concentrated in 4 periods. The first 8 years, the 5 hospital period, the Great Depression and World War II period, and the World War II to independence period. And independence came in 1960. So what can we say about this early medical work? First of all, the early missionaries had great faith and great courage. They had few treatments for many diseases. Independence came in 1960. It was sudden and unexpected. Even so, the medical groundwork was well laid with our 5 hospitals. But the greatest legacy of the early Presbyterian medical work in the Congo was compassion for the Congolese people.
La docteure Judith Brown est une anthropologue sociale qui utilise les méthodes d'enquête et d'observation participantes pour comprendre la santé des communautés dans les pays en développement. Ses travaux ont porté sur la nutrition, le planning familial et le VIH-Sida. Pendant 20 ans au Congo, Bulape, Kananga et Kinshasa, Judith a travaillé avec les églises presbytériennes et l'Église du Christ au Congo. Elle et son mari Richard ont 2 filles, l'une née au Libéria et l'autre en Tunisie. Ils ont également vécu en Haïti, au Cameroun et au Kenya.
Let's continue the story of Presbyterian medical work in the Congo, focusing on the Kasai regions with the period 1960 to 2020. I call this new freedoms and new difficulties. First, there was a new nation. Independence from Belgium came on June 30th, 1960. It was a heady time for a few days, but then political upheaval and fighting and all kinds of troubles. 101 foreign Presbyterians left the country during that bad time, but 45 were able to return within 6 months. There was still continuing unrest for some time, but finally in 1965, General Mobutu Sese Seko seized power and was able to bring calm and stability. During his tenure, his long tenure, he renamed the river and the country and the money Zaire. He ruled the country as a military dictator, and he became extremely wealthy in the process. But he failed to foster real development. During this period, there were an estimated 440 hospitals throughout the Congo. You can see here that the government owned and operated about half of them, and the churches most of the rest. The Catholic Church, which was stronger than the Protestant Church around the country, owned even slightly more of the hospitals. The Presbyterian hospitals included these in the Kasai regions: Libanga, Bulape, Lubondai, and Luebo. The Presbyterian Church in the USA sent medical personnel and funds and supplies, always as requested, by the Congolese. During this period, the Christian Medical Institute of the Kasai continued for a while to operate at Lubondai, but then it moved to Kananga City, really to a campus a ways out from the city at Chikaji. IMCK was jointly operated by 3 Congolese churches, the Presbyterians, the Mennonites who worked in the areas to the west, and the Methodists who worked in the areas to the east of the Presbyterians. For practical training, the students had to leave their school at Chikaji and go to the church hospitals all around the region. In 1974, the IMCK Laboratory School opened, and shortly after that, the Good Shepherd Hospital opened there at Chikaji. The hospital was followed by the hydroelectric dam, which was big enough to provide electricity not just to the hospital, but also to the school buildings, the dormitories, and the faculty homes. New health facilities in Buji-Mayi included the Presbyterian Health Center, which opened in 1980. And back in Kananga, IMCK renovated and opened the PAX Clinic downtown, including dental and eye services. Here's an aerial view of the city of Kananga, and beyond that big traffic circle, you can see the white buildings of the PAX. An exciting time was when the first Congolese doctors began to arrive to work in church hospitals. Dr. Nzangu came in 1976 to Chikaji, and Dr. Katambwe to Bibanga, and then a few years later, Dr. Chiswaka and Dr. Chibangu. This was a period that community and preventive medicine were growing rapidly around the world, but particularly in Congo, Zaire. The Presbyterian Church in the USA sent doctors who were trained in public health, and they trained Congolese teams who began community health censuses to find out who was where and who needed the various health services. The teams began malnutrition prevention and treatment activities. They held mobile services in rural villages. The preventive services included child nutrition, family planning, and immunizations during this time. The next 20 years we're calling the collaboration or health for all period. The nation continued to be economically exploited, a great deal of poverty, not much progress for ordinary Congolese, and uprisings here and there from time to time. Due to major unrest in 1991, many donors withdrew their personnel and funds from the Congo, and the medical and health zone work faltered, but then it recovered and continued with overseas help, particularly from the churches. Medical training even improved during this period, with more medical and nursing schools opening through the country and with interns training in church hospitals. A new school of public health opened in Kinshasa, and the Kasai doctors could earn the Master of Public Health degree and return to their hospitals to work with the health zones. 1980 to 2000 still was health for all, or Santé pour tous. Healthcare was extended to offer good, basic health services to even more of the Congolese people. The National Health Plan clearly defined health zones. Each zone was to have 100,000 people, and it was to be served by 10 to 20 health centers spread throughout the zone and offering prevention and cure, and one hospital for referral and surgery and training. Here's a 1985 map of the 306 health zones that existed at that time. You can see the different regions of the country on the map according to the colors, but within each region there were many smaller health zones, each containing 100,000 people. The zones were managed by the Ministry of Health, nearly half of them. then by the Catholic Church and the Protestant churches, another half, and a few by companies and NGOs. Each health zone was expected to oversee community activities throughout its area, about 10 to 20 health centers where basic care was given, and then the reference hospital where serious cases could be hospitalized, including surgery. And also the reference hospital usually had the office of the whole health zone, and it stocked the medicines and equipment for the entire health zone. So who paid for all this? Well, patients paid fees for their curative services and their medicines. The Ministry of Health and overseas partners supported the preventive activities. For example, the SANRU projects. They were funded by the United States government and helped to train and supply 100 health zones. Many were in the Kasais, such as Bibanga Health Zone, the Bulape Health Zone, the Chikaji Health Zone, and others. Meanwhile, a new disease had emerged, Ebola fever. It was first identified in Congo in 1976, and all that could be done was to try to figure out how it was spreading and to take care of people and try to keep it from going to other people at the time. Eventually, once it was understood better, educational materials were produced and used throughout the Congo as needed. Several more outbreaks occurred in Congo since then. Another new disease was HIV/AIDS. It was first identified in the United States in 1981 among homosexual men, but it soon appeared in Africa, and transmission of the disease there was mainly by sexual contact between males and females, and also the transmission could be from mother to child in utero. HIV/AIDS in the Kasais in the late 1980s saw health workers beginning AIDS teaching and testing, trying to help people to prevent being infected. In the 1990s, the hospitals saw large numbers of AIDS patients, large numbers of deaths. In the late 1990s, there were finally medicines available, but they were not available in Congo. They were far too expensive. And by the late 1990s, the nation hit some major changes. First, the rebellion that organized in the eastern side of the Congo and then moved west, with the troops walking, as you see them here, walking all the way to Kinshasa. There they deposed President Mobutu after 32 years in power. The new century began with hopes for its new presidents, but things did not continue well. Kabila, father and son, continued to rule again for 22 years. Eventually, elections brought to the presidential palace Felix Tshisekedi in 2019. What was happening in the nation? Well, the population continues to increase. There's spotty economic development, even for an increasing population. There's continuing unrest and rebellions, particularly in the mineral-rich areas of Kasais and elsewhere. And there have been, during this period, population displacements in the Kasais and elsewhere. What's happened in the Kasai health facilities? Well, there are some new technologies, solar energy, better cell phone and internet access, for example. There have been some renovations and upgrades at Moma Hospital, Lubondai Hospital, and many rural health centers. The PAX Clinic in Kananga City now has a new Center for Women's Health. Training during the last 2 decades has seen family medicine residency programs for doctors, and IMCK has added university-level nursing courses in midwifery, pediatrics, and health administration. During this 20 years, the health zones continued to be coordinated by the Ministry of Health. SANRU has now become a permanent Congolese organization, helping many health zones tackle many problems, and SANRU has many donors from overseas. IMA, Interchurch Medical Assistance World Health, and others in the United States and Europe continues their support for activities in the health zones, the hospitals, both rural and urban. And 2020 has seen newer diseases continue. HIV/AIDS is no longer new, but the treatment is now affordable thanks to the United States government PEPFAR funds and other countries. But new infections continue, lots of them. Ebola fever is now in its current outbreak of the 11th in Congo. All of them so far have been outside the Kasais. And now the new disease is COVID-19. Let me close by acknowledging the book that gave us a lot of our information on the early periods from 1906 to 1980. The book is A Legacy Remembered by Sophie Crane, written and published in 1998. Thank you.
Le Dr Jacques Makambo Badibanga est le directeur médical et le coordinateur des centres de santé et de maternité de la communauté presbytérienne de Kinshasa. Il a fait ses études dans les écoles presbytériennes de Lwebo et de Katubwe et a obtenu son diplôme de médecin à la Louvanium, plus tard l'Université nationale du Zaïre, et à l'école de santé publique de l'Université de Kinshasa. Il a été à la fois médecin de santé publique et coordinateur technique du projet SANRU Santé rurale. Il est un ancien dirigeant de la congrégation Binzabrikin du CPK. Le Dr Makambo est actuellement aux États-Unis pour les soins de santé de son épouse.
Je suis Dr Jacques Makambo Badibanga, ancien médecin directeur du département presbytérien de santé. L'édition 2020 de Congo Mission Network nous a demandé de présenter un bref historique du département des services de santé de la communauté presbytérienne de Kinshasa. La première date que nous avons à retenir, c'est l'année 1890 qui marque l'arrivée des premiers missionnaires presbytériens américains, révérend Shepard, noir, révérend Lapsley, un blanc, leur arrivée à Boma. Leurs écrits se trouvent sur un grand arbre à Boma qu'on appelle le baobab de Stanley. Le 18 avril de l'année suivante, c'est-à-dire 1891, ce fut le début de la mission presbytérienne au Congo, située à Lwebo dans le Kasai. La mission du Kasai en 1930 a envoyé des catéchistes à Léopoldville pour encadrer les anciens élèves presbytériens qui priaient chez les baptistes à Léopoldville. Arrivée l'année 1954, les baptistes ont invité les presbytériens à Kinshasa pour les épauler dans la mission d'évangélisation, car Kinshasa prenait de l'extension et ils étaient dépassés. L'année suivante, en 1955, les deux missionnaires presbytériens qui étaient envoyés à Léopoldville sont partis. Il s'agit de John Morrison et John Coffin pour commencer la mission presbytérienne de Léopoldville. Le 10 juin 1955, le roi Baudouin a accordé la personnalité civile à la mission presbytérienne de Léopoldville avec John Morrison comme représentant légal. Et en 1957, l'église de Yolo devient une paroisse particulière. Le 17 janvier 1960, il y a eu la création de l'église du Christ au Congo avec la section presbytérienne de Léopoldville. L'année 1970 a vu la création du premier presbytère de la CPK à Kinshasa. En 1974, ce fut la dissolution de la mission presbytérienne de Léopoldville en faveur de la communauté presbytérienne de Kinshasa. En 1983, il y a eu la création du synode unique, ce qu'on appelle Saint-Synode et son installation. Ce synode a cheminé jusqu'en 1992 avec 45 églises particulières et régionales, 40 églises sous tutelle, ce qui a permis de créer d'autres presbytères, 3 synodes et former une assemblée générale. Ça, c'est brièvement l'historique de l'Église. Maintenant, nous allons parler de l'historique du département presbytérien de santé. Au moment de l'indépendance du Congo en 1960, la ville de Léopoldville avait moins d'1 million d'habitants et était dotée de 5 grands hôpitaux bien organisés. La mission presbytérienne de Léopoldville n'a pas trouvé la nécessité d'en construire d'autres à ce moment-là. Mais avec l'exode rural, la population est passée de 400 000 en 1960 à près de 10 millions d'habitants en 2011. Beaucoup de cités se sont créées sans normes d'urbanisation. Les hôpitaux existants ont été débordés par la surpopulation. Les médecins américains qui travaillaient à l'hôpital général de Kinshasa, ex-Mama Yemo, avaient ressenti le poids de cette population sur leur travail. Ils ont convaincu les missionnaires presbytériens qui étaient à Kinshasa de s'impliquer dans la construction de nouvelles structures de santé. C'est ainsi que le service médical de la CPK est né. Le département médical a vu le jour et le département presbytérien de santé s'est intégré dans le projet Santé pour tous du gouvernement. Et le département a mis sur pied un programme de création des centres de santé. Et pour ça, nous avons eu l'appui de l'Église presbytérienne des États-Unis en ressources humaines, l'appui technique, comme directeur adjoint au niveau du département. Et le premier, c'était Annette Kraner, et le deuxième, c'était le couple Larry et Inge Strechley. Les directeurs successifs au niveau du département sont, le tout premier, c'était Samuel Chiswaka. Il était aussi technicien de laboratoire. Le deuxième, c'est Étienne Lumbala, technicien de laboratoire. Le troisième, c'est Dr Jacques Makambo Balivanga qui vous parle, médecin. Et docteur, actuellement, c'est Dr Ziko Ntumba Mukendi. Alors, la CPK aussi a eu un important appui financier de l'Église presbytérienne des États-Unis à travers la structure qu'on appelle Outreach Foundation. Avec cet appui, il y a eu la construction des centres de santé. En dehors des centres de santé qui étaient sponsorisés par nos partenaires, il y a les paroisses qui ont pris l'initiative de construire leurs propres centres. Donc là, ce sont les quelques photos des centres de santé que nous passons en revue. Là, c'est le centre de santé Kitoko. C'est toujours Kitoko. Le suivant, c'est Bonsuba. Ça, c'est le centre de santé Mayamba. Centre conçu en 84, maternité en 2000. Ça, c'est toujours Mayamba. Ensuite, nous avons le centre de santé Chimungu. Les photos que vous voyez là, il s'agit de l'inauguration des sanitaires qui ont été construites avec le financement de l'ambassade des États-Unis au Congo. C'est l'ambassadeur lui-même qui est venu pour l'inauguration. C'est la même cérémonie, vous reconnaissez des gens là-bas, il y a le pasteur Chimungu, il y a Larry Strechley, il y a moi-même qui suis là, et le staff. Ça, c'est le centre de santé des centenaires, construit en 1991. Centre de santé Liboke, construit en 1994. Centre de santé maternité Chiswaka, construit en 2009. Mudishi, centre hospitalier Mudishi en 2015. Alors ensuite, nous avons les structures de santé des paroisses. Ça, c'est le centre de santé de la paroisse CPK Ndili 3, constitué de 2 bâtiments. Ça, c'est le premier bâtiment. Ça, c'est le deuxième. Ça, c'est le dispensaire de la paroisse CPK Ngaba. Ça, c'est le centre de santé de la paroisse CPK Lokoro, Quelles sont les activités qui sont menées dans ces centres? Nous prenons en charge les malades, nous soignons les malades courantes, les maladies courantes. Nous pratiquons la consultation préscolaire pour les enfants de moins de 5 ans. Nous avons aussi la consultation prénatale pour les femmes enceintes. Nous avons des maternités, la chirurgie générale et laboratoire. Nous avons les activités de jardinage, nutrition avec la promotion des moringas. Là, ce sont les quelques images en rapport avec les activités que nous menons dans les centres. Là, ce sont la consultation préscolaire avec la pesée des enfants. Là-bas, c'est l'éducation sanitaire donnée aux mères des enfants avant la vaccination. Là, c'est l'image de maternité. Nous avons une maternité là. Là, c'est un cas opéré, c'est la chirurgie. Et là, ce sont les intrants que nous avons reçus de l'Église presbytérienne des États-Unis pour lutter contre le COVID-19. Quelles sont les forces du service médical de la CPK? La première force, c'est que nous avons un staff qualifié. 7 médecins, 52 infirmiers, 7 techniciens de laboratoire, un administrateur licencié en gestion financière. Nous avons des infrastructures de santé en matériaux durables. Nous avons l'informatisation pour les statistiques et les finances. Nous avons les différents partenariats avec l'Église presbytérienne des États-Unis, avec le presbytère de Eastern Virginia, avec l'UNICEF, avec le gouvernement congolais et tant d'autres. Nous avons aussi l'existence de la Fondation presbytérienne qui nous apportait des intérêts générés par les banques chaque année. Et enfin, nous avons l'existence des conseils d'administration et des comités de gestion pour encadrer la gestion. Quelles sont nos faiblesses? Les faiblesses du service médical de santé de la CPK. Il y a le délabrement des infrastructures, des équipements. Nous avons le manque de matériel roulant pour la supervision des centres. Il y a l'insuffisance des recettes dans les centres de santé en rapport avec les coûts des soins. Nous avons l'incapacité de prendre en charge les soins de santé des pasteurs, puisque tous les pasteurs de la CPK, quand ils sont malades, la majorité préfère venir prendre les soins de santé gratuitement. Comme opportunité, les structures de santé de la CPK sont situées dans une cité bien définie, dans une ville définie. Ils ne sont pas éparpillés dans plusieurs provinces, mais c'est dans une ville. Une autre opportunité, c'est que les grands ONG du niveau national ou du niveau international ont leur siège à Kinshasa. Ça, c'est une opportunité. Quels sont les défis que nous avons? Le premier, c'est que nos centres, les structures de santé sont logées, localisées dans les zones, dans les aires de santé très pauvres. Et les aires de santé qui sont très même difficiles d'accès. Pour y accéder, même avec un véhicule 4x4, c'est difficile d'arriver dans les centres. Deuxième difficulté que nous avons, c'est qu'il y a la construction anarchique des autres centres de santé des privés qui viennent faire concurrence à nos centres dans les mêmes rayons d'action. Nous avons encore une grande difficulté, un grand défi, c'est la pauvreté de la population. Il y a des malades qui viennent, ils n'ont pas d'argent pour payer, alors on ne peut pas, en tant qu'Église, on ne peut pas les renvoyer, mais on les prend en charge. Une autre difficulté, c'est que le budget que le gouvernement alloue au service de santé est faible. C'est un budget qui n'est pas adéquat. Le système d'assurance n'existe pas pour la population. Chaque malade qui vient est obligé d'avoir l'argent dans la poche pour payer, mais ils n'ont pas toujours cet argent. Enfin, comme dernier chapitre, nous allons exprimer quelques besoins essentiels. J'ai dit bien des besoins essentiels. Il y a un manque criant d'un véhicule pour la supervision, étant donné que les centres sont dans les endroits difficiles d'accès. Pour y accéder, au moins un véhicule 4x4, pendant la saison sèche, c'est possible d'arriver. Nous avons besoin d'avoir un approvisionnement régulier en médicaments, même une fois par an. Si nous pouvons avoir un réapprovisionnement régulier de médicaments, ça peut aider beaucoup. Nous avons aussi besoin de renouvellement périodique des équipements et la réhabilitation des bâtiments des centres de santé. Les besoins ici, c'est le dernier chapitre de ma présentation. Et Ça, c'est le baobab de Stanley pour marquer l'histoire de la CPC, de l'Église presbytérienne au Congo. Ces baobabs entrent dans l'histoire de notre Église. Shepard et Lepsley ont passé la nuit dans cet arbre. Merci pour l'intérêt que vous avez porté à notre présentation. Que Dieu vous bénisse.
Nous commencerons par une présentation du Dr Larry Streshley, le directeur national d'IMA en République démocratique du Congo. Il est titulaire d'un doctorat en santé publique de l'Université de Tulane et avec sa femme Inga, il a été collaborateur de la mission presbytérienne au Congo où ils ont tous deux grandi. Larry est un leader mondial dans le développement de systèmes de santé publique. Monsieur Manon Taingi présentera également sur notre thème. Il est directeur de renforcement des systèmes de santé à IMA et le responsable du programme pour leur projet COVID-19. Il est titulaire d'une maîtrise de l'université Johns Hopkins.
Hello, my name is Larry Streshley. I'm a co-worker in DR Congo. Welcome to CMN 2020. I've been asked to speak to you about the work of the church and the work that I've been doing in COVID-19, and specifically looking at how it compares to what happened in the US. As a health professional, this has been really interesting to dig into what happened in Congo and compare it to another country. A lot of things haven't gone well in Congo, but from the looks of it, what they've done with COVID-19 has been pretty impressive. In dealing with the pandemic, the guidelines for addressing that pandemic are pretty similar throughout the world. So it's not too hard to compare what happened in Congo to what happened in the US. Here are the key statistics for the pandemic. The first numbers are the total numbers as of September 8th. But I think what's more interesting is to look at the cases, at the numbers that are compared to 100,000 population. There we see that the US has about 2,000 cases per 100,000 population, and Congo only has 12. Now, there's probably a lot of underreporting in both countries. I've seen some articles saying that in the US it's about 10 to 1, that they're only catching about 10% of the cases. Congo, maybe you can compare it to what's going on in India, where it's about 30 to 1. But even if you look at those missing data, it's still a huge difference between what happened in the US and what happened in Congo. On the deaths, the US had 59 per 100,000. In Congo, it had 0.13 deaths per 100,000. The death rate was about the same in the US and in Congo. And that would make an argument that maybe we're not missing as much in Congo as we assume. Here are the measures that we need to take to control COVID-19. These are the guidelines that are out there. Now, there's probably a different list, but this is the one that I put together from looking at multiple sources. So it's pretty universally accepted that you need to wear a mask and social distance as long as the pandemic is going on. Avoid large gatherings. Avoid interacting with others in closed spaces. And the guidelines for starting lockdown. I'm surprised that this is not more publicized, but it is quite available if you look for it. Basically, what they're saying is that if you have 1 death per million population, you need to be going into lockdown. So this is something that you would come and go from as the pandemic progresses. To test whether you can come out of lockdown, you have to depend on the positive testing rate. but that is only accurate if you're doing about 150 tests per 100,000 population per day. So if you are doing that number of testing, then you should stay in lockdown until you start seeing a 2-week reduction in the numbers of new cases, and the total number of positive cases is only about 5% or less. So how did the US and DRC compare on this? So with the masks and social distancing, it's hard for me to say exactly what's happening in America because I'm far away from it. But from what I see in the news, it looks like it's been pretty inconsistent in applying that policy. Some places apply it, others don't. It's become very political. In Congo, is a very clear message. It's mandatory to wear masks in public, and it's enforced with a fine. But still you see people on the street not wearing masks, but it's rare to be inside of a store or any building and not see people wearing masks. The indoor gathering. Again, sometimes it seems like in the US it's discouraged but not outlawed. Other times it seems to be outlawed, but it's often not followed. And there's been these very large rallies and events that have kind of been super spreaders. In Congo, on the other hand, when they put out the order that no meetings or no gatherings of more than 20 people, it was surprising how well that was respected. For 4 months, you didn't hear churches going on, you didn't hear bars going on. I was really quite surprised at how universally that was accepted. I was not expecting that. So for starting the lockdown, using this 1 death per million population guide, only 15 states applied that correctly in the US. The rest delayed by sometimes only 2 to 4 days, sometimes for weeks. I think the average for, well, there was a difference between Democratic and Republican run states, but the longer one was for almost 3 weeks before applying that. Whereas in Congo, even though we never reached 1 death per million, even if you look at just the population of Kinshasa, where most of the cases were, they locked down and they stayed locked down for 4 months. On testing, neither country did well. The US took 2.5 months to get up to the level that was considered sufficient, and that, from what I can gather, again, was sporadic. Some places had it, some places did not. In Congo, it was never achieved. There was never enough testing going on to really know what was going on. And then for ending lockdown, it seemed that in the US, there was a lot of pressure to end lockdown quickly. So even though the guidelines were out there, people rushed through those guidelines. I saw that in some states, even though the testing rates were above 20%, they were still getting out of lockdown, whereas they should have been staying on until they had gotten those positive tests down. In Congo, because we weren't doing enough testing, the positive tests did go down, went down to about 8% and never reached the 5%. But for a full month, in fact, over a month, the number of cases consistently went down before they left lockdown. The video I'm about to show you is from an interview that I did of Mano Tangani. Mano has worked with me for about 15 years. He's very good with his relationships with the government, and so he is the director of health system strengthening within IMA World Health. When COVID-19 came on, we assigned him to be the director of that program, so he's been managing that for the last 4 months. What did the government do to address COVID-19 in Congo?
Okay, thank you very much, Dr. Larry. The government of the Democratic Republic of Congo was informed that COVID cases were, coming out from China, but it wasn't until March 10th that the government get involved here in Congo, as the first case was confirmed in Kinshasa. So what they did basically was to set up a task force around the president and a national committee, multi-sectoral committee around the prime minister and the minister of health. And at the coordination level, they have to put a commission, a response commission that was led by the Dr. Muyembe, which worked closely around the INEAB, which is the National Institute for Biological Research. So that was the main step that the government take, but this technical committee around Dr. Muyembe has the mission to set up a national response plan, which was articulated in 9 commission or objectives, if you want. The first one was to set up a governance system that should help in the coordination of all the country effort in trying to stop COVID. The second one was to make sure that there is a sound treatment procedure that is in place to take care of all the patients that was being diagnosed. And the third one was to put in place a system where the diagnosis can be done correctly. So they have to train lab and make sure that they are trained diagnostic kits in the country to do the testing. And the second one was to make sure that infection is controlled in all the air facilities, particularly to avoid that health worker can get easily contaminated. So they have to put in place a measure on infection and control to prevent that. The other one was to set up a system to improve risk communication and community engagement, so people are aware of the risk of getting the diseases and they act appropriately. They also set up a group to supervise all the coordination effort around surveillance and case tracking, which was really important. In addition, they also set up a commission to do all the logistics, because logistics is very important in emergency situation.
Here's the timeline of the controls that were put in place in Congo. So starting on March 10th, that's when the first case came in. Within 9 days, the government had put out a mandate that no gatherings of over 20 people, churches, schools, sit-down restaurants were all closed, and incoming flights from maybe 8 countries, these were Asian and a few European countries, required quarantine for 14 days. But Inge and I went to South Africa in February, even before this was happening. And when we came back, they checked our temperature on the tarmac right as we got off the plane. So you could not even get on the bus to go to the terminal until you were cleared. I know that, they were very used to doing this because this is the same procedures we had in place for Ebola. But as soon as Congo started hearing that there might be something out there, they applied that to every flight coming in. By March 23rd, so 4 days later, all international flights were banned. And coming and going from Kinshasa required special approval. The rest of the country, people can move around. By April 6th, there was obviously a concentration of cases in the Gombe area, which is the downtown region of Kinshasa. And so they put that whole region, or that whole district, into confinement. You could not come or go from that without a pass from the INRB, which is kind of like the CDC of Congo. This scale is not proportional. That shutdown of Gombe lasted for 2.5 months before they opened it up. And when they did open it up, they allowed businesses to start up again if they were essential. A month later, they opened up banks and restaurants and bars. On August 3rd, they opened up schools, and then by August 15th, they opened up the airport again for international flights and domestic flights. Also, churches started meeting again after August 15th. So this is what it looked like as far as the number of cases and where they were on April 6th when they shut down Gombe. And you can see that 64, I think probably out of maybe 100 or so about half of the cases were in that one Gombe area, and that's why they shut it down. I had a pass to get into Gombe because my office is within the Gombe area. And I had to be going to meetings with the government during that time. So this is what we went through whenever we went. I still only went maybe once every 2 weeks through this barrier. But you had to get out of your car, show your pass, get your temperature taken, wash your hands, get back in the car, and be let through. Because of these strict measures, this is what was achieved in Congo. You can see that there was a spike, around June, July, and it's been consistently going down ever since. The blue is the Kinshasa area, so you can see predominantly all the cases, or most of the cases, were in Kinshasa. And the yellow that you see over to the right, that's North Kivu. So that's been where the newer cases have been. For the last 3 weeks to a month, Kinshasa has had an average of less than 10 cases per day. This is where we are today. There's 10,000 cases. Only 2,262 are outside of Kinshasa. And officially, there's 262 deaths. There's probably more deaths than that. But when we look at national statistics coming through the hospitals and other sources, there hasn't really been a big spike in deaths. And so this is not too far off from what really happened. Something that's kind of amazing is that there's 96% of the cases are being contact tracked, meaning that the list of the people that they have come in contact with for the last 2 weeks is being registered, and those people are being followed up with. Like I said, the testing is low. It's only about 377 per day, but the overall positive rate is down to about 8.5 now. As is the case throughout the world, it's the elderly that are dying the most. So about 9% of the cases coming in are over 65. But 36% of the deaths are of that age group. And those that are dying, as in the rest of the world, have complications of hypertension and diabetes, for the most part. So what did we do, IMA World Health, working along with the church to address COVID? After being contacted by DFID, we wrote a proposal and we got $6 million of funding from UK Aid to respond to COVID-19, mostly in Kinshasa. About 5 million of that is in Kinshasa. and the rest is for Kasai Central and Nord Ubangi, other provinces that we work in with other projects. For the Kinshasa work, we contacted 3 church groups, the ECC, which is what the Presbyterian Church is a member of, ADRA, and Salvation Army. These were chosen because they have about half of the healthcare system of Congo is delivered by church groups. And these are the groups that are most active in Kinshasa. We did training, we rehabilitated some health facilities, we supplied personal protection equipment and other equipment so that about 186 health facilities could respond effectively to COVID-19. This is a picture of training the community volunteers. Every health facility in Congo has 20 to 60 volunteers that work with them. And so there are an army of people that will help with vaccinations, with nutrition programs. But when COVID came along, they were the ones that were recruited to do the messaging to the population. They took the message down into the homes, explaining what people needed to do. They had megaphones and they went through the streets, giving the message. For about 3 or 4 months in Congo, every time you made a phone call, you didn't hear a ring on the other side. You got a COVID message. It got quite annoying after a while, but it made it so that every day most people heard the message over and over and over again and knew exactly what they needed to be doing. Here's one of the hospital wards in Kimbanseki that was rehabilitated with the money from UK aid. One of the more exciting parts of the project was to connect with church groups, or women's groups mostly, to make masks, because the surgical masks, one, they were restricted. Both the US government and the United Kingdom put restrictions on us buying surgical masks because they were needed for the health personnel. So there was a lot of pressure to make masks and get them out to the population. One of the groups is the CPK. You see Mama Masenga next to Christy Boyd. So she mobilized her team. And to the left is a Subco Baptist missionary and the head of the women's department for the Baptist church. And then there was a smaller group called Tabitha, which independent church. But these 3 groups made 100,000 masks in 45 days. And now we've given them a second contract for another 75,000 masks that they're going to make in September. Another part of the message is washing your hands frequently. And so part of the project was to fabricate out of metal, construction metal, 550 hand washing stations. And these were distributed along with cleaning supplies and personal protection equipment into health facilities and a few churches. This is at a health facility, and you can see the checking of the temperature using the flashed thermometer and the hand washing. But it's throughout the city. You cannot go into any public building, whether it be an office building or a grocery store, the government building, everywhere requires you to have your temperature taken, to wash your hands, and to wear your mask when you're inside. We avoid going out as much as possible, but it's reassuring that when we do go grocery shopping, everybody is abiding by these rules? I think the question everyone has is, were the public health measures that the Congo government put in place sufficient to make the low case rate and the low deaths, or is there something else going on? I asked Bono this question, and this is his response.
There are many opinions on that. Some people think that Congo has been underreported. As you just learned from India. So in India, they are talking about, for one case reported, there were about 33 to 130 cases underreported. So this brings up a total number of millions in India now, which is, I think, the second or the third leading country in terms of cases. But the case of Congo actually is a little bit, I would say, strange, because you don't see a lot of death. So it can suggest that there are very few cases compared to other countries. But I would say ecological, the environment of Congo, and may have played a big role here in making that very few people get sick here. This is one part. But the other part is that some health prevention activity that promoted hand washing system here in Congo, with almost every facility, restaurant, church with hand washing system, also created a setup that people can easily understand the risk and quickly change their behavior to avoid transmission. I think that plays a lot. Project like SSR, project like Sanru, in the past, I would say 20 years from now, have worked a lot in teaching people how to wash their hands before in critical moments, like before, after coming to the toilet, before eating. All this, I think, have played a big role in educating people to avoid getting the diseases. But we have to say that God has played a big role as well, protecting the people of Congo, given the fact that we have problem with the infrastructure in Congo. There are very few, for the whole country, I'll say we have less than 100 ventilators. So if we have to have severe cases of COVID, it will be very difficult to handle that. So I'll say this is on the place.
Okay. Is there anything you want to add?
Yes, I would like to thank all the church groups that have been involved in Congo, and it's important that this support continue in the future, because missionary around here and church group around here are very supporting the health system in Congo. And I have a few examples. One of the church in Gili, actually, we have a project. We are rehabilitating the hospital that is in this church. Actually, is supporting even people who are poor, who can't afford to pay health care. So they are putting people first, and not money as other public or private health facilities are doing. So it's best that those churches that have program be supported to continue to support the people in Congo, most of whom are still poor. Thank you.
Okay, thank you. So there's differing opinions as to why Congo did better, but this is my list of why I think Congo has done better than other countries in keeping their cases low and their deaths low. The first is what I've been talking about here, which is that they applied and followed public health guidelines better than most countries. Second thing is the age distribution of the population. 46% of the population is less than 15 years old, so most of them are asymptomatic. There's only 2.7% that are over 65 in this high-risk group. And as you remember from the graph I showed before, 9% was of this group was the total number of patients of new cases. So they were heavily hit. It was obviously more in the older crowd, and they died off more. But there's so few of them, it would have been much worse if there'd been more in that age group. And as I mentioned earlier as well, Congo has this long history of contact tracing for Ebola. And so these relays that we used, they've all been trained in this before. So it's just a refresher course, and they could apply what they learned before for this new disease. And that's made it so that even though there's not much testing going on, the testing is targeted for the people that were most likely come down with the disease. After that, we're getting much more speculative. But an observation I made is that, and all of you that have visited Congo can attest to this, that almost all socialization in Congo happens outside or in the church building or a gathering like that. So when those large gatherings were outlawed, most of the interaction with people that you would be getting COVID from was in the open air. And the literature is pretty clear that you're much more likely to have a low exposure if your first encounter with COVID is outside as opposed to inside. It's a dose-dependent disease, so the less you get a dose of it, the less severe you will have the disease. So both mask wearing and interactions outside will make it so that a large proportion of the population has been exposed, but they were probably asymptomatic. I have an anecdotal example of this. A company that we associate with, we rent our office space from them. They decided to test every one of their workers. So from the CEO all the way down to the night watchman, they tested their population, their staff. And even though this was done back in April, so before the spike, 20% of their staff were positive, but they were all asymptomatic. So if that is representative at all of what's going on in the population, it supports the idea that there has been more exposure, but much of it is asymptomatic exposure, either because of the dose or the age of the people that are being exposed. You'll also see articles out there trying to figure out why Africa in general is having lower caseloads and lower deaths. And one theory that's put out is that because of all the disease that people have to face on a regular basis in Congo and throughout Africa, and the fact that vaccination coverage is much higher here in Africa than it is in Europe or the US, that there's probably some immunity already in the population for a lot of diseases, and COVID might be one of them. Now, this might be a partial immunity, which would mean that they are getting sick, but asymptomatic, or it might be more complete immunity than that. So there might be a part of the population that's not ever getting sick. I'm going to end on this slide with links in it. They are very helpful videos or sites that I used as I put this together. I think one thing that kind of shocked me as I did this is that it's actually quite easy to find out exactly what you should be doing and when you should be going into lockdown, what you should do to come out of lockdown. This information is available to decision makers in both countries. and to individuals if they want to find it. And the fact that a country like Congo, with all of its problems, took the time, took the leadership to follow these guidelines and protect their population is commendable.
In today's conference, we first addressed the topic of healthcare in DR Congo and how this new virus, COVID-19, has affected Congo. Dr. Streschley noted various contrasts between the situation in Congo and the situation in the United States. Experiences of countries with COVID have varied. At present, Congo has had a limited number of COVID cases, while the US has the highest number of COVID cases in the world, and over 200,000 Americans have died from COVID. In my church alone, 3 members have died with COVID. The American society is affluent, but the lifestyle and culture of travel, work, and consumption have been devastated by this tiny virus. We are reminded again of our fragility and vulnerability in life. Next, we will hear from 3 people who have contracted COVID, 2 people in the United States and 1 person in Congo. Around the world, we witness the range of human reactions to this virus. Some people have no symptoms and quickly recover, while others are sick a while. Still others require temporary hospitalization, and of course, others die. Our 3 testimonies of people who have survived help provide us with a perspective from the point of view of both experience of suffering and hopeful trust in God. Our next presenter with a personal story with COVID is Pastor Susie Grade. She is co-pastor of Platt Park Church in Denver, Colorado. She earned a bachelor's degree in education at University of Wisconsin-La Crosse and her master's in leadership at Denver Seminary. She has worked in churches since her 20s and with the international organization called Food for the Hungry. She and her husband own a business and they enjoy activities with their children. She loves co-creating environments where people can encounter God and reconnect with Christ.
Hello, friends in the Congo Mission Network. Although we've never met, I have heard of your good work, and I thank God for your lives. Hearing about you and your work has been an encouragement to me and to our church, and we thank God for all that He's doing in you and through you in the world. My name is Susie Grade, and I'm a pastor at Platt Park Church in Denver, Colorado in the U.S. This past summer, I tested positive for COVID-19. I was vacationing at a lake area in northern Wisconsin when I became sick. And at first, I just felt tired, and then a little fever set in. And after 3 days, I also developed a dry cough. It was not a productive cough, but when I went to take a deep breath, I'd have to cough when I went to take a deep breath. And on the 3rd day of being sick, I was not getting better. So I called the clinic and I was asking if I could get tested, and I was able to get a test that same day. So I went immediately to get the test. And then I stayed home after that and self-quarantined while I waited for the results. And for about 7 days, I was sleeping most of the day, 18 to 20 hours of each day. I was just sleeping. And on the 5th day of being sick, I lost my sense of taste and smell. I was able to recover at home. I never needed to go to the hospital. I just slept a lot. And today I am very grateful to report that I am feeling 100% better. I have had no lingering side effects from COVID. When I was sick, I spent most of my days just sleeping. I think my body was telling me that a lot of rest was what I needed physically to both endure coronavirus and also to regain my strength physically. Spiritually, I received encouragement from my family and through music and prayer. And even though we are on opposite sides of the world, I feel that we are in this global pandemic together. And so I leave you with the words of the author Frederick Buechner, who said this: "Here is the world. Beautiful and terrible things will happen. Don't be afraid." And I love that quote because I always think it's interesting that whenever an angel appears to a human in scripture, the first thing the angel always says is, "Do not be afraid." I think the reason we do not need to fear is because God is always with us. No matter what we go through, God is always with us. Even when we go through the valley of the shadow of death, we fear no evil because God is with us. So I pray that you stay safe and healthy and free from fear as we face this global pandemic together. Grace and peace in Christ, my friends. Grace and peace in Christ.
Our next presenter with a personal story with COVID is Mr. Igwoso Pauline. He is interviewed by Dr. Ntumba Mukendi Samuel. The interviewer, Dr. Ntumba, is employed in Kinshasa by the Congo Presbyterian Community of Kinshasa, that's CPK, as director of the CPK Medical Department. Interviewer, Dr. Ntumba, graduated from medical school at the Medical School of Lubumbashi in 2003 and completed his internship at IMCK in Chikaji. He's married, has 3 children. The person who contracted COVID, Mr. Igwoso Pauline, is a nurse serving on the staff of CPK. He lives in the Lemba commune of Kinshasa, is married, and the father of several children. He serves as the nurse in charge of the Chimungu Health Center of the CPK and tells his experience with COVID here.
Oui, moi c'est Paulin Igwoso. Je suis infirmier dans un centre de santé, alors de la place en ville de Kinshasa. J'ai reçu ma soeur venant de la Belgique, qui est passée en vacances chez moi. Après un certain moment, elle se sentait un peu la fièvre, la toux, éternellement tout consort. Alors j'ai essayé un peu d'appeler l'équipe de riposte qui sont venus chez moi à la maison. On l'a pris, on l'a amené à l'INRB pour faire des examens nécessaires. Et de là, on a trouvé un cas suspect, on l'avait isolé. Et après, il était positif. Il était positif. Alors, ainsi, on est venu chercher le cas de contact chez moi à la maison. Moi et toute la famille, on a prélevé tout le nécessaire pour aller examiner au niveau du laboratoire INRB ici à Kinshasa. Et parmi toute ma famille, il n'y a que moi qui étais touché. Alors, c'est ainsi qu'on m'a isolé, on m'a donné les traitements. J'ai suivi les traitements. Et maintenant, je me sens très à l'aise. J'ai repris quand même mon service après un repos. Et je me sens trop à l'aise. Vraiment, je suis en train d'encourager l'équipe de riposte qui a fait un travail très efficace. Sinon, j'allais vraiment succomber. Parce que je sentais très mal à la gorge, la fièvre. Je ne sentais même pas l'odeur. Même pas l'odeur. Et parfois un peu de douleur thoracique. Et franchement, j'étais très mécontent parce que quand on me dit que voilà, j'étais contaminé, alors vraiment j'étais très mécontent, mais heureusement j'étais mis sous la cure et je me sens trop à l'aise, je suis guéri. Alors je remercie l'équipe de riposte qui a fait un travail efficace et pour moi et pour la belle-sœur qui est rentrée en Belgique. Et jusqu'aujourd'hui nous sommes en communication avec elle et vraiment elle se porte bien là où elle est. Et moi aussi, dans ma maison, je suis très bien avec mes enfants et j'ai continué à prester mon service comme d'habitude.
Mais à tout le temps que tu as eu à faire à la maison, comment tu te présentais? Est-ce qu'il y a eu le problème de finances qui s'est posé? Ou comment tu faisais maintenant pour nourrir ta famille? Parce qu'au Congo, on sait que les gens vivent autour du jour. Est-ce qu'au service, tu as eu à dire que tu as été contaminé de Covid?
Oui, j'avais quand même annoncé aux amis que je suis malade, je ne saurais pas arriver au service. Mais heureusement, la vie est difficile au Congo, mais on a essayé un peu de se passer. Bon, on vivait comme à la guerre, parce que moi, je suis le poumon de la famille. Comme on n'avait plus rien, bon, on cherchait des voies et moyens pour avoir un pain journalier. C'est ça l'essentiel. Mais du moins, j'avais communiqué aux amis. Mais de mon retour de service, j'avais peur. J'ai dit non, moi je suis déjà guéri parce que je n'ai rien payé comme argent. Même les examens nécessaires, je n'ai jamais été donné quelque chose comme 1 franc. On me traitait gratuitement et grâce au projet IMAN qui nous a soutenus vraiment en finances, en médicaments et tout consort. Sinon, vraiment, je remercie quand même ces services-là.
Ok. Maintenant, la famille, quand ils ont su que tu étais malade, comment votre famille s'est présentée? Comment leur attitude, comment leur comportement, c'était comment?
Oui, j'étais un peu trop frustré. Hein. J'étais trop frustré parce qu'ils savaient que moi, c'est le poumon de la famille. Vous savez, quand le poumon est malade, vraiment, tout le monde avait de panique. Ils disaient, mais est-ce que le papa, il va faire quoi? Mais Dieu est grand. On a eu les traitements, on a eu ce qu'on pouvait avoir et on a eu la guérison.
Est-ce que après avoir su que tu étais malade, même tes voisins, quand ils ont su qu'il y avait quelqu'un qui était contaminé chez vous et toi-même, comment, quand les gens te voient maintenant que tu es guéri, qu'est-ce qu'il y avait une discrimination envers toi ou les gens avaient peur de toi?
Oui, les gens avaient peur au départ et surtout quand il y avait l'équipe qui était venue désinfecter à la maison chez moi. Bon, les gens étaient un peu curieux de savoir ce qui se passait. Bon, l'équipe a fait son travail, ils ont désinfecté la maison. Ils ont fait tout ce qu'ils pouvaient faire. Et bon, en fait, maintenant, je suis en contact avec les voisins. Je suis en train de bien causer avec les voisins. Il n'y a plus de problème.
Ok, merci.
Moi, je vous remercie. Monsieur Iman, je vous remercie.
The next person we hear from with a personal story about COVID is Pastor Tim Reynolds. He's currently the pastor for worship, discipleship, and mission at Second Presbyterian Church in Knoxville, Tennessee. He was born and raised in Gallatin, Tennessee, and graduated from the University of Tennessee. After a 10-year career as a professional musician, Tim enrolled at the Columbia Theological Seminary, where he received his Master's of Divinity degree. He has been a teaching elder in the Presbyterian Church USA for almost 20 years.
Greetings, friends. My name is Tim Reynolds, and I am one of the pastors at Second Presbyterian Church in Knoxville, Tennessee. And I bring you greetings from the congregation which I serve. We are grateful for your ministry and for your service to Jesus Christ and for the way that you are glorifying God through all that you do. And so we want you to know that our prayers are with you and that we are grateful for you. I've been asked to share a little bit about my experience with the coronavirus. First of all, I want to say that I took the virus very seriously from the very beginning and was very cautious about where I went and what I did. And our communication to people was that this is how we love one another in a global pandemic. We show our love for one another by not gathering together, by not touching, by wearing our face coverings. This is how we protect one another, and this is how we respect life. Despite my best efforts at being vigilant and not doing things that would put me at risk, I still contracted the virus. The symptoms started as body aches and a sore throat. And then the second day, I had shortness of breath. and nausea and some diarrhea. By the third day, I had developed a headache and sinus problems, a runny nose, watery eyes, as well as a fever. So the fever came on the third day. I got sick on a weekend, and so there was no place to get tested. All of the clinics were full, and none of the public places or my doctor were open. Finally, on a Sunday, late Sunday afternoon, I found one clinic where I could get tested, and they told me it would be a few days. I had been sequestered at this point ever since I had gotten sick from my family, and I was fairly sick. I had horrible body aches, terrible headache. My chest hurt. I had developed this dry cough, and I was really sleepy, very lethargic, could not get out of the bed or off the couch. I got the results of the test on a Tuesday, and it was negative. So I went back upstairs to where my family was, but I did not get better. And so by Friday, when I was still sick, I had been sick for a week, I went to my doctor, who gave me a second test, and that test was positive. And I'm told that this is a common thing, that sometimes people get tested the first time and it's negative, and then they get tested a second time and it is positive. I was sick for another week after that. So for 14 days, I was very ill, but I did not have to go to the hospital. The doctor had told me that if I had difficulty breathing, that I should go to the hospital. It hurt to breathe, but I did not ever have enough trouble breathing that I felt like I needed to go to the hospital. The only medication I had was rest and hydration. I also had what they call a pulse oximeter, which you put on your finger, and it measures the oxygen in your blood. And the doctor said if that had gone below 90 to go to the hospital, but it never did. So it was rest and drinking water. I also drank Gatorade. After the second week, I started feeling better. It still took me another 2 weeks before I felt back to normal. The third week, I was very tired, very lethargic, had a difficult time getting up and out of bed and moving around. Then the next week, that got better. Now it is mid-September. I still occasionally have a symptom or two. Yesterday, I had the cough. A few days ago, I was tired. So I just have to pay attention. But what I want you to know is that I got better with no medicine and just the support of my family and congregation. I also want you to know that those 3 days that I thought I was negative, I was with my family. I was in the same bed as my wife and in the same car as my wife, and I was at the dinner table with my children, and none of them got sick. So we don't know why, but we are thankful to God that they did not get sick. So they were in the same household as me, but did not come down with the disease. So I would encourage you to not ostracize people who have the disease, because it is possible to be near people and not get sick. This doesn't mean we shouldn't take precautions, however, and it is important that we do take those precautions. But sometimes even with the best precautions, we can still get sick. So I hope this helps you in your understanding of what can happen if you get the coronavirus. I am back to full strength just about now, except for the occasional symptom here and there. And my wife and children never got sick. So again, we thank you for all that you do for the gospel. We thank you for your ministry, and we will continue to hold you in our prayers. And we would be grateful if you would pray for us as we navigate this uncertain time as well. In the name of Jesus Christ, go in peace.